I'd like to introduce Dr. Michael Sprintz, who has a pain practice and an addiction practice down in the Woodlands outside of Houston. Michael has been innovating for a long time. He is an anesthesiologist who is trained in pain medicine and addiction medicine, and he's got a story that he can share with you too. He's been a key advisor to us. He is also the CEO of an organization that has really done some innovative things with a prescription drug monitoring program called Solarian, and you're going to be able to hear about that during one of the breakouts tomorrow. We've also got Manu Mathews, who had an exciting morning this morning. He blew a tire out on the way down from Fort Smith, but he's here safely now, and we're happy to have him. Manu used to run the pain center at the Cleveland Clinic, and he's a bit of a rare bird. He's not only boarded in psychiatry and addiction medicine, but he's also pain fellowship trained and pain medicine boarded too. So he brings to us the experience of running one of the top-notch pain centers in the United States, and then coming to a county hospital in Fort Worth that largely serves the underserved, and the challenges of standing up a multidisciplinary team approach to chronic pain and substance use. So without further ado, let's have Michael and Manu take over and give their presentation.
Thanks a lot, Dan, for those kind words. My apologies, because you guys had to take your break sooner because of me. I'll blame Elon Musk for it and his refusal to put a spare tire in a car. So for the first time in my life, I got a ride of 100 miles on one of those tow trucks, so it was fun. All right, so I'm going to start off this talk. I'll probably talk for about 20-25 minutes, and then I'll hand it over to Michael. So briefly, like Dan said, I work in Fort Worth in a county hospital. I direct a pain program there, which was very different from what I was used to for 10 or 12 years before I got there. But it's been fun, and it's been a great learning experience. I've learned so much over the last few years too. So, well, we have actually, over the years, we have come multiple full circles, and we are all here with trying to figure out what do we do with chronic pain and addiction. But we all know that the elephant in the room, the unsaid issue is, chronic pain would not have been felt to be such a big problem by most practitioners had it not been for the opiates. We don't have many pain doctors or primary care doctors tearing their hair out because people want multiple epidurals. That's rather rare. And opiates, morphine being the primary one, has been around forever, right? So there are historical documents of 5,000 years old when some of the ancient tribes used to call it the joy plant. And it probably arrived here with the first people to come step foot on soil here. And there's some evidence that the doctor who came on the Mayflower had morphine with him. And over the around the 18th, 19th century, it became rather common, sold at street corners, in pharmacies, in all sorts of places, regular stores and all of that, for a variety of maladies. And as you can see, it was, if you can see that picture down here, Mrs. Winslow's soothing syrup, and there's this mother giving this stuff to a little baby, and there are a couple of them expectantly looking for their dose of the same thing. And it was a pretty strong concoction of both morphine and alcohol. I wish I was a baby then. So. And Bayer, which we all know is a huge multinational company, found its footing with heroin and aspirin. Aspirin went on to save a lot of people, and heroin not so much. But heroin was the big seller, not so much aspirin. And like with most stories of great wealth, it usually starts with damaging a lot of lives. So this is another example. So I need to get into something of this sort. All right, so the use of morphine, and there are descriptions of how soldiers who returned from the Civil War were addicted to morphine. And in the early 19th century, or rather in the early 20th century, was the first time that the government started to take notice of the problem of morphine addiction. And they started to formulate laws in regards to who can import it, because before that, anybody could just transport any amount of morphine from any part of the world and sell it in the United States. So people started to notice that there were a lot of people who were losing their lives. And earlier part of the 20th century, people started to use this in medicine, or doctors started to prescribe it. But the use was pretty limited among the licensed or group of people or among physicians. To the point where there was so if you look at this JAMA article from 1941, it was, other than for cancer, even for cancer, it was not to be used, right? So it was really restricted, and doctors had a real stigma about it. Because there was this whole fear about addiction with morphine, because they had seen it in the historical past, 30, 40 years back, a lot of it going on. The cycle kind of slowly changed, the tides turned, and in the late 80s, in the early 90s, there was increasing literature about how pain was untreated or undertreated, how medications were underutilized. There was a lot of concern about there being some real racial differences in in the treatment of chronic pain. And so 1995 was kind of an eventful year in our specialty, because at the APS, at the American Pain Society's meeting, James Campbell, please do note the name, and I apologize if any of his friends are here, and I meant it. He, in his president's address, he declared pain, he suggested that pain should be made the fifth vital sign. So that's where that whole thing about pain being the fifth vital sign, that was the first time that idea was proposed. Although the American Pain Society, it's not a regulatory organization. It's, they don't really set the standards of care throughout the board, because there are other pain-related organizations. But this was the first time such a strong suggestion was made, and people took notice. Incidentally, in the latter part of 1995, OxyContin was approved by the FDA for use for sale in the United States, and I think the US was the first country where it was approved. So in early 1996 is when OxyContin came to the market. And around this time, in the mid-90s time, there seems to have been, now at that time it might have felt like it was uncoordinated, it was just coincidental, it was the tide of the times. In retrospect, there must have been a bit more of an agenda or planning around this. So this type of article, no excuse for pain, doctors have the means to alleviate suffering of millions, why aren't they doing it? Rather sensational. So front cover of US News and World Report, Time, and I think even Newsweek ran major articles on this issue. So it really brought to the front and to the fore this whole thing about chronic pain. And as you can imagine, people have been living with chronic pain for probably as long as people have been around. But all of a sudden, there was a lot of press around chronic pain.
There's no question that our best, strongest pain medicines are the opioids, but these are the same drugs that have a reputation for causing addiction and other terrible things. Now, in fact, the rate of addiction amongst pain patients who are treated by doctors is much less than 1%. They don't wear out, they go on working, they do not have serious medical side effects, and so these drugs, which I repeat are our best, strongest pain medications, should be used much more than they are for patients in pain.
As a good doctor said, these are the most powerful medicines available for the treatment of pain, And if used in patients with pain, the risk of addiction is less than 1%. And you would imagine that that kind of data would have come from some robust experimentation or clinical studies, or at least some sort of a database. And that one piece of information or one piece of data or study was repeated over and over and over and over again for over, I did my fellowship in 2008. I heard it even then. So I kind of wondered, oh, wow, this must be an amazing study. And I went back and started looking for it, and I realized that a lot of other people had looked for it too, so I didn't have to look too hard before I came upon it. So this was a New England Journal of Medicine letter section from the late 70s. And Dr. Herschel Jick and his assistant Jane Porter had written a letter to the editor that was less than 100 words in total, where they claimed that they had looked at 39,000 odd patients who had been treated with opiates, and 3 or 4 of them got into trouble with opiates, and all of those had pre-existing addiction history. What they failed to say in that letter, and I believe unintentionally, was that these are all inpatients treated for a brief period of time that they never followed up with. And this one piece of data was used widely by pharmaceutical companies at that time. This gave physicians and a lot of physicians, hospital administrators, insurance companies, everybody, a false sense of security when it came to opiates. And as we know, the prescription of opiates started to go up. And if you look at that figure there, in 98, 99, that's when it really started to take off. And it was great because, and I'm not kind of trying to bear down on Purdue Pharmaceuticals by any means, they just seem to have reaped the greatest benefit from it. There are a lot of other pharmaceuticals who are engaging in the same thing. And one of the purposes of my talk is not to put blame. It's just so that we can put things in perspective, and because, a wise man has said, if you don't know where you came from, you will never know where you're going. And if you don't learn from history, we'll always repeat it. So at least so we know about the history of this, so that we don't step into these same potholes again. So OxyContin sales started to go up. And interestingly, a few other things started to happen, right? So there was all this press that was of chronic pain was getting. These nationally recognized organizations that were talking about it. And around that time, in 1999, the VA actually was the first organization to actually declare pain as the 5th vital sign. It was not JACO, it was not CMS, none of these organizations. The VA was the first major healthcare provider to make this an agenda. And in '99, they required that a numeric rating scale be obtained for every patient for all clinical encounters across the VA. I've actually read this booklet that they published. It's, I think, less than 100 pages, but a reasonably good publication. But a lot of this emphasis was placed on how to manage medications and how to escalate, how to add in different types of medications, primarily opiates and so on and so forth. And a year later, JACO came out with the statement that pain should be assessed and managed in all patients. So they never declared the 5th vital sign as their primary agenda. They just said, hey, you need to assess pain and you need to manage pain. And in one of their sections, they do refer to it as the 5th vital sign, and they call assessment and management of pain a fundamental right of the patient. JACO has since spent a lot of time and has gone through a lot of effort to absolve themselves of any wrongdoing. Might be partly true, but when you ask a physician or anybody to assess something and to manage it, and when you have very little tools to do the latter part, you're going to default to whatever is the easiest and most available. And Michael is going to talk a little bit more on some of those challenges. It was not until 2006 that the CMS published the HCAP kind of monitoring or scoring system. And they tied in some of these metrics that they would get in the HCAP surveys to what is called, I think, the value-based purchasing, where hospitals would get, depending on the percentage that they scored, they would get incentives or extra payments, or they might face penalties. So the HCAP questionnaire that every hospitalized patient might get by phone or by mail is a composite of 22 questions. And of the 22 questions, there are only 2 that are related to clinical stuff. And both those things are questions pertaining to pain. So you could go into a CMS-funded hospital for a pneumonia, and they might mistakenly go ahead and amputate your right arm, but CMS has no interest in knowing about that. All they want to know is, after the amputation, was your pain controlled at all times? Right? And the other thing they would like to know is if the hospital staff did everything to control your pain. Now, which begs the thought, how does the patient know everything that can be done? So it's all a perception, right? So this had a tremendous impact. And again, CMS never asked anybody to prescribe opiates, right? But the patients are in the hospital. Nurses walk into the patient's room every 20 minutes, twice a shift. I think I was just being, I was exaggerating. Twice a shift, and they ask the patient for a pain number. Once they get a pain number, they document it down, and they inform the doctor, whoever is in charge of the patient. Now, CMS never asked the doctor to do anything about it, but hey, you're supposed to do something. You have data, you're supposed to do something. So people do stuff. And so, Dan said, I'm a psychiatrist too. So one thing that I know is behavior that is rewarded gets repeated. So every 4 hours, you walk in and ask a person, hey, what's your pain? And if he says something, and then you go ahead and do something, the next time you go and ask him the same question, he's going to say something similar. So you reward it, and again, the next time it gets repeated. And so it basically ends up like chasing your own tail. So the primary way that CMS will rate the hospital on is the patient has to say that they always, the pain was well controlled. So if you had a terrible amputation, motor vehicle accident, whatever, it doesn't matter. Your pain has to be always well controlled. And so I work in a level 1 trauma center where people get flown in and brought in from all sorts of places with polytrauma. I have no idea how you could expect their pain to be always well controlled, short of having them on an IV, bag, almost obtunded. And that's what we have seen, right? So in the Cleveland Clinic, I used to run the inpatient consult service too. And at one point, in order to improve the HCAP scores, which used to be not very good despite our best efforts, we actually gave so many PCAs that we ran out of PCA machines. And we thought we need to order more. You can't put in more than one. So someone came up with the idea, why not give 2? So it just starts to get crazy at that point. So as expected, we started to see an increase in the opiate dispensing across the country. And interestingly, the use of other substances started to come down. And I remember as a psychiatry resident, my addiction attending telling me, what, it's amazing that, and this was in mid-2000s, it's amazing that I don't see as many of those other, I'm not seeing as many cocaine, inhalants. I think the addiction problem is on the wane. We are probably going to get over this thing. So we are all pretty happy about it. But what we didn't know is that we were actually creating a different one. So all we were doing was cross-addicting people from all sorts of other substances onto prescription drugs. And this data, everybody knows, the mortality started to go up. more people going to the emergency rooms. And since there are many people here from the insurance industry, we know, you guys know that we are spending billions and billions of dollars on opiate-related ER visits. And there is another characteristic. Patients on opiates not only go to the ERs or to the hospitals or make phone calls more for directly related to opiates, even for other stuff. They don't take good care of their blood pressure. They don't take good care of their diabetes. They end up using a lot of resources. I'll skip through some of the next few slides because we all know about how much it's triple, quadruple the amount of opiates that are being dispensed. United States has 5% of the world population, consumes 99% of the hydrocodone produced in the entire world, consumes 85% of all opiates produced in the entire world. So, and when I was a resident, there was a 1991 article which described how 30 million Americans were afflicted by chronic pain. And by the time I reached my fellowship, there was a new article that was dated, I think it was same, again by Dennis Turk, from 2002 or 2003, that told me that now 100 million people were afflicted by chronic pain. And between 91 and 2008, we had done a lot. Didn't seem to have made a difference. And so by 2010, the tide changed. The Institute of Medicine's report about the deaths, the same cycle started. Time Magazine, Newsweek, US News and World Report, all of them started talking about the damage that was being done. This is what has happened to the heroin use. As you can see, it's gradually been creeping up, and this is data up until 2013, but it's substantially more after that. And this is what has happened to the deaths related to heroin. So as the deaths from opiates, prescription opiates have kind of slowed, or the rate of increase has slowed down, the number of deaths from heroin use has gone up. And we have been barking up the wrong tree, perhaps. So multiple studies have shown that if the closer you try to monitor people's pain, the poorer the outcomes are. You try to, healthcare industry is very different from all other industries. This is we can all agree that there is a certain element of customer service involved, but it's not to be dispensed out in the same way that, perhaps selling a car is. There are a lot of other factors that play into this. So if there's a market, there's always going to be a supplier. So this is the opium production in Afghanistan over the years. So if you look at the chart, you see that 2001, it went all the way down, right? Any guesses about what happened? Sorry? No, this is opium production in Afghanistan, which is the primary source for opium all over the world. In 2001, the Taliban took over the government, and they actually destroyed all the poppy plants. But in 2002, they got freedom. So we were there, and the cultivation went right up. And somewhere in the late 2000s, the US Army tried to reduce production again, but they learned that if they were to take the crop of the farmers and destroy it, then these farmers just picked up guns. So they said, you know what, let them do what they want. So they went back right to making morphine. So it's more complex. It's not just one-dimensional. So now, and this chart does not include the latest figures. So if you see there, that graph, this was like the wild predictions about 5-6 years back. Now, this year's this chart goes up to 8,000 tons. And that is the maximum it goes up to. Actually, in 2017, they made 9,000 tons. And we know that this is also a result of socio-economic policies and outcomes that we have now. For every 1% raise in unemployment, there's a 4% raise in addiction and 7% increase in ED visits. 40% of applicants to the state of Ohio either failed or refused a drug test. Now, I have quite a few friends in the auto industry. They tell me how hard it is to find a reasonably educated guy or girl who will turn up to work every day and do what they're supposed to do in the United States. It's not because of an absence of jobs. It really is a big factor that we are facing now is the lack of skilled and disciplined workforce. So over the years, Social Security disability applicants have gone up, and as you can see, this is kind of a function of the economy too, and as the economy has improved, the applicants and the awards have come down a little bit, but as you can see, it's at a historic high. And if you are an otherwise reasonably healthy person, all humans or all animals are meant to do something useful with their day and life. If you don't have that, you are going to seek solace in some way or form. That is the rule of the world. We have seen that happen for centuries. We have seen that happen with the Native American tribes. We have seen that happen with people in the Inuvik area. We have seen that happen with people in Siberia. You take away the purpose of life from a person, they are going to seek some form of solace. And this, it's not entirely surprising that we get this. So what we know now is that you use a lot of non-pharmacological things, acceptance, biofeedback, yoga, injections, exercise, rehabilitation. People will get better with if they have chronic pain. And but it almost seems like people didn't know this before. But interestingly, I actually copied and pasted this from a 1986 NIH document. We knew all this stuff that we know even then. It's just that in the middle, we lost our way. We went out and we were kind of, every morning we were shown a new squirrel or a rabbit, and we went chasing after that, only to find out 25 years later that we have killed off about 300,000 people. We have, hundreds of thousands of families have been damaged or destroyed irreversibly. The damage that this causes, chronic opiate use, chronic pain, causes not just to the person. In fact, if the person is knocked out, it's not as painful to watch as it is to see their kids or their spouse struggle with it. And that is what we have done. And we are actually, I don't believe that we are at the peak of this problem. We have created an entire next generation of customers for people such as me, unfortunately. Because there are millions of kids who have not had a childhood, who have spent their entire lives afraid, unparented, and all of that stuff, who are, and we know that we have already sown the seeds for another generation of addiction, because what we are doing now to them is exactly the things that are going to trigger off addiction in the next generation. So did we not know anything? Well, this is Ed Covington, my boss from the Cleveland Clinic. He never changed his practice. How he practiced in 1980 is exactly how he practices now. And it was the gold standard now. It still is the gold standard then. So people who knew and were not swayed by all these rabbits running around were still doing the right thing. So what really works? There's a lot of, so this Wilbert Fordyce is a psychologist who came up with some fantastic philosophy of managing chronic pain, which is really a summary of which is the biofeedback, getting people to move, getting people to take ownership, accepting the chronic pain, and moving on with their lives. This has been, so that's basically I'm talking about a multidisciplinary or a functional restoration program type of model. It works really well, but patients have to be engaged in it for weeks or months. Previously, before good surgeons would operate, they would force their patients to go to back pain school and get rehabilitated, and only if things didn't get better would they operate. None of those things exist now. It's very effective, but it's expensive. And in today's world, nobody wants to think beyond their next quarter. And there is ample evidence from the functional restoration programs that managed to survive at the Cleveland Clinic, Mayo Clinic, at the Tampa VA, that if you take patients, put them through functional restoration, wean them off opiates, they actually do better. Their pain improves, their function improves, rates of relapse on opiates are significantly lower, and 3 or 4 of those papers are mine. You put these people who have been through restoration programs, you help them get insight into their addiction, put them on Suboxone, they actually do fantastically well. So the outcomes can be better. But pills were cheaper, injections were more lucrative. Everybody's looking for instant gratification. Our average life attention span is less than 10 minutes now, so we want something to happen real quick. And so we all went towards whatever was easier and quicker. Physicians have not been angels in this either, right? So we have, I don't know how many physicians are in this room, but I as a physician can say that we have actually allowed all other sorts of people and interests to hijack what we should be doing. And so we actually went along with them out of fear, out of greed, or a number of other reasons. And now we find ourselves marginalized in the conversation. We forget being, at one corner of the table. We are not even in the room when these decisions are being made. And I think we have a big role to play in this. And the gentleman that I mentioned earlier, James Campbell, he was actually the president of the American Pain Foundation, which actually was shut down because they were basically a front for the pharma industry. So he was the guy who gave the 1995 talk. Now we have come a full circle, but we are facing another different challenge. Things that actually work are being denied, are being pushed back. So we who work in this, we know that. So this is a couple of prior auth sheets from these are commonly used in Texas by many of the insurance companies. One of them the one on the left is for gabapentin. It costs like less than $4, or maybe 10 at the most, or $20. It's cheap. It works for a variety of problems, but very few of the patients would actually fulfill that criteria. The other one is for Celebrex. It's full of holes. I looked up the company. They don't have any doctors or anybody on their team. It's a bunch of businessmen with one pharmacist who are writing policies that insurance companies are buying and implementing. And in the battle between my time and a customer service representative time, I'm always going to lose. And one drug that still, to date, in our practice, does not need prior approval is a short-acting opiate. God forbid you do anything other than that, you're going to spend a lot of time on the phone. And like the wise men at OxyContin at Purdue Pharmacy recently said, they're only getting started, right? So we were the test bed for this, and now they are expanding to other countries. So it's truly a multinational business now. I'll hand it over to Michael. Thank you for...
Just a quick note. So in addition to being, I'm fellowship trained in pain, I'm an addiction, boarded in addiction medicine, pain, anesthesia, but I've also been in recovery myself from drugs and alcohol for over 17 years. So I have a lot of perspective, both from a personal standpoint and, thank you, I had a tremendous amount of help, and a professional standpoint. So as we sit here and we talk about it, okay, here we are, we know we've got a problem, and it's getting worse, and what do we do? One of the problems that we've had right now in addressing the current problem is the fact that there's a lot of things that are going on in terms of our response to this opioid crisis that are resulting in outcomes that we don't necessarily want or not necessarily achieving the end result. There's a lot of money going into addressing the problem, but we still have some problems in leveraging that money in a way efficiently that gets the results that we're looking for. So some of the problems that we have is reactionary legislation. There's a lot of states are enacting legislation as it relates to opioid prescription. Some of these legislation don't have research or there's not enough evidence behind it, but yet everyone's looking for an answer to this problem now. And what that does is that starts to change behavior. So there's a big chilling effect among providers as it relates to prescribing. And let me be clear, so even pain, addiction, all that, I also prescribe opioids to appropriate patients for appropriate reasons. And if it's not appropriate, I don't. And that's a really important thing. There are certain areas and certain conditions where opioids are appropriate. The problem is that we haven't differentiated or understood, how do I determine that? How do I understand when it's not appropriate? And how do I figure those things out? And unfortunately, a lot of the providers, we hadn't been trained in that. So what's happened is there's a fear of prescribing, fear of going to jail or loss of license or prescribing opioids. The sudden changes that have happened where a lot of primary care docs were prescribing for a long period of time, and we saw it first when they rescheduled hydrocodone, October 6th of 2014, they rescheduled it to a Schedule II. And so a lot of docs stopped prescribing, and the pain doctors, we all got a huge influx of patients because my primary care doc who'd been prescribing, Norco for the last 15 years isn't anymore. And I had an interesting comment from a primary care doc who was really frustrated, where he said, look, I can be held liable for negligence for undertreating pain, yet at the same time I can lose my license for overtreating pain. And I'm not an expert in either pain or addiction. And it was a true frustration that he had. So the sudden changes in the prescribing habits have been leaving a lot of patients to go into withdrawal or being forced to illegally buy opioids. And we're seeing that, and as they looked at the data where, opioid prescriptions are decreasing, and everyone was cheering and shouting, and they were like, but we've got this massive problem with heroin overdoses. Come on, of course, addiction is an inelastic demand, and if you decrease the supply of available opioids, people who are physically dependent and addicted will find it elsewhere. Regulatory guidelines have the effect of intimidating providers because even though they are not rules, they're not standards of care. As providers, there's always the fear that what if I have a bad outcome and I'm sitting on a stand, that suddenly I'm going to be liable. So everyone goes and tries to stay as safe as possible. Ultimately, our goals are always for the best care of the patients, and sometimes there are conflicting issues as it relates to that. Payer reimbursement limitations. As Manu had said a lot of times, and this had happened significantly in the past, that they were only covering non-abuse deterrent formulations of short-acting opioids. There are now coming up, I've talked with a lot of other pain docs, where there's a blanket pre-authorization requirements for opioids as well as opioid limitations. And that's been a huge problem because there hasn't been enough discussion or thought about when is this appropriate, when is this not appropriate, and there are patient situations where it can cause a lot of problems in that delay. Overly burdensome pre-auths for urine drug testing. That's one of those things where urine drug testing and the prescription drug monitoring databases are two objective measurements that help us understand what our patients are doing when they're not in our office. And those are really important parts, and the goal always is to support medically appropriate testing and therapies while diminishing fraud, waste, and abuse. And part of the reactionary response has been to limit a lot of that. Plan limitations on opioids without increasing access to care for withdrawal management and treatment. All right, if you're going to cut me off of the opioid I've been on for 15 years, then help me. Help me get off of it safely, and that's been one of the challenges. And then there's been a delay in the reimbursement of or limits on effective non-traditional or complementary pain management modalities. And the beautiful thing is this is why we're here. This is the goal, so we can start to educate one another and move towards policies that will help us. So this isn't intended as a bash, it's intended of really shining a light on where are we now and where can we go. There's not enough focus on education and changing perceptions, both in the medical community and the public, surrounding the stigma of addiction. And then there's an internal debate within the addiction medicine community. I call it the abstinence versus the mats. Okay, so I grew up in the 12-step program, and in my practice I have a good, strong MAT program as well that's integrated both with pain and behavioral health, or with behavioral health. The problem is everyone's dug in one way or the other, and part of all of this is about it really does take a comprehensive approach from a multi-system viewpoint in order for this to work. Abstinence is a great goal, just like it is with diabetes. If I can get you off your insulin with diet and exercise, that's fantastic. And in the meantime, here is some insulin or some oral, hypoglycemics to help you. But the goal is to get you down there. It's the same with buprenorphine. We would love to have you not necessarily need it and to give you skills and tools to help cope with life on life's terms, and we can handle the physiologic parts. But in the meantime, this is helping you go to work, to stay in treatment, to do all the things you need to do while we help you develop skills and tools. Lack of consideration for unintended consequences. That's the big problem, is that sometimes the laws and policies don't result in the intended result. And one of the things within Narcan Rescue that there's a lot of debate about, it absolutely saves lives. The question is, now what? And what can we do with that? Where if we're to have a lot of resources spent, sending out EMS to help someone without a plan to get those people who we just rescued to a level of care or education, and to start that process of helping them get into recovery, is we end up throwing a lot of money at the problem without necessarily the results, and that's, again, why we're here. There's a ton of money being thrown at this problem, which is good. Anytime we have a lot of money anywhere, sometimes there are greeds and ethics problems, and that you're going to find that in any industry. The other part is that there's a lack of defined success metrics, and that's part of this discussion, is how do we define those success metrics so we can most efficiently leverage the resources that are being addressed at this problem. All right, so what can we do? So from the 50,000-foot view, this is really a big picture idea, is that you want education. We all need to be educated, providers, public, legislators, payers, everyone. We need to understand the problem better and more accurately. Identifying patients is important, as well as identifying prescribers is important. Having an infrastructure that can support withdrawal management and help people move from addiction into recovery, and from chronic pain into recovery, because the overlap is astounding. Developing effective treatments, as well as, again, measurement and adaptation. Clay was talking earlier about this in terms of the lean startup. We need to be able to refine practices when we find practices that work, and stop doing things when we find out they don't work. Value-based care delivery. Value-based, it's derived from measuring health outcomes against the cost of delivering outcomes. So the idea is that you get paid for delivering better outcomes. It makes sense. I think back in the day when people first started the HMOs back in the 90s, at least that was part of what we were talking about. I think we have the ability to measure a lot better, and technology interwoven with healthcare delivery, in my opinion, is where we're going and where we need to go in order to do that. So what can we do? Well, for the providers out there, it's about education, educating yourself, insisting on educating, learning, because whether you're in primary care, pain, addiction, outside, outpatient or inpatient, the fundamental issues are the same. We're in the American Society of Addiction Medicine, we're refining and starting core competencies in pain medicine for addiction providers, because pain doctors often struggle with, how do I manage addiction? And addiction doctors really struggle with, how do I manage pain? And that's really kind of what I do. This is why I'm still here and didn't die. And so we're trying to help educate addiction doctors on the basics of pain, and educating pain doctors on the addiction on the basics. Reevaluate your practice, and then address concerns. Swinging the pendulum the other way from, okay, I'm going to prescribe for everyone, to I'm not going to prescribe for anyone, causes more problems. Beware of alcohol and sedatives. They're coming. If you don't believe me, start looking at the data. And ideally, don't just discharge a patient if you find they have a problem. Refer them to a specialist, which includes communication. Hospitals, education of staff. Identify inappropriate prescribers before you have a sentinel event. That's really key. And quite honestly, when you deliver better health care, when you identify patients with opioid problems early, you get them into a system, you get them in recovery, it saves money. I mean, the economics are there, it makes sense. For payers, look to revamp policies that may help in the short term but worsen the problem in the long term. We've talked about pre-authorizations for medications, as well as for urine drug testing. Supporting pre-authorizations, or supporting payments for withdrawal management medications like buprenorphine and other medication-assisted treatments. There's more than buprenorphine out there. Okay, and then reimbursing for and supporting behavioral health therapies and pain management therapies that are complementary or alternative. And that includes not just providing access, but also reimbursing at appropriate levels that enable healthcare providers, especially behavioral health providers, to be able to take on insurance rather than having to take cash. That's a big problem that we struggle with. Value-based care delivery is really a win-win negotiating mentality. We can create the outcomes of better outcomes at lower cost actually can work if we all understand that and that everyone needs to win. Communicate with your teams to understand total patient costs. A lot of the larger industries are siloed in terms of claims data between medical, behavioral, and pharmacy. So John Smith doesn't seem nearly as expensive to the medical side, yet behavioral and pharmacy are like, oh my God, this is crazy. Again, unsiloing that helps. Support innovations of technologies that help identification and management of addiction as well as treatment and prevention. Anything that technology is the best way that we can leverage and scale on this issue. Pilot projects and appropriately incentivizing adoption of new technologies. Support alternative payment models. And employers, recognize your power. Employers are incredibly powerful in terms of their benefits and in terms of their influence on payers. Being educated about that is absolutely vital so that as employers understand, and there's talk about them being in trouble for lack of fiduciary duty to their employees by wasteful benefits packages as it relates to healthcare. And that's really, really big and significant. Legislators, please pause before legislating. Ask yourself what might be the unintended consequences, and then ask someone else. You know, there's a bunch of us that are subject matter experts, and we're really, really good in some areas, and you know what? We may not be entirely correct. So ask another person as well to gain some basic a check on that. Focus on establishing long-term programs starting immediately rather than quick fixes. This is a long-term deal. It is a very complex problem that doesn't have a simple solution, but there is a solution. It's just multifactorial, and you have to perceive it from a systems level, because this impacts this, and this impacts this, and if we impact that, then we can touch this, which impacts the end result. And thinking about it that way as we communicate, and then we can start to enact policies and rules both on a regional, national, and state level to make a difference. And then community. Again, we were talking about this. Community is absolutely vital, both in supporting evidence-based recovery programs and also using media to destigmatize both chronic pain and addiction. And then I'd like to quote Margaret Mead. In 2012, when I started or was finishing up my pain fellowship, I sat there and I thought about it, and I wrote on my desk, I'm transforming the paradigm of chronic pain and substance abuse. And that was where I was in 2012, and everyone thought I was crazy when I kept talking about, you know, chronic pain and addiction. They're like, what are you talking about, dude? But here we are. And what was great is, you know, never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has. So this is why we're here. This is what we're doing. We have that opportunity. And don't forget that you guys all have a lot of power right where you are. And if we all do this together, we are going to start making those changes. Thanks.